Morning, everyone. I am presenting. Morning, everyone. My topic is psychotropics in renal and hepatic impairment, and my moderator is Dr. Alpita Negi. Psychotropics in hepatic impairment. Cytochrome P450 in the liver is responsible for the metabolization of most antipsychotics. Antipsychotics can induce liver injury by hepatocellular, cholestatic, and steatosis means of mechanism. The risk of hepatotoxicity with chlorpromazine is well established among typical antipsychotics. Atypical antipsychotics really induce severe liver toxicity. A type of hepatic lesion associated with antipsychotics can follow a primary hepatocellular pattern. Therefore, the main change in laboratory test seems to be an elevation in aminotransferases. It is important to assess liver function tests before initiating treatment with typical antipsychotics, and subsequently routine control of aminotransferases must be performed. The most used anti-epileptic drugs in psychiatry are valproate, carbazepine, topiramate, pregabalin, and gabapentin. Of these drugs, valproate is associated with greater risk of potential liver toxicity. Gabapentin and pregabalin are the safest. These are the recommended psychotropics in hepatic impairment. For antipsychotics, sulpiride and amisulpride, no dosage reduction is required in renal function if renal function is normal, and paliperidone can be suggested if report is required. Under antidepressants, paroxetine, sertraline, citalopram should be started at low dose. For mood stabilizer, lithium can be used with guidance in plasma levels, and care is needed if ascites status changes. For sedatives, lorazepam, oxazepam, temazepam can be used in low doses with caution, as sedative drugs can precipitate hepatic encephalopathy in severe disease. Now, psychotropics in renal impairment. Psychotropics should be rationalized to minimize the risk of direct nephrotoxicity. Creatinine clearance test is considered as a marker of renal function. The kidney excretes few first-generation antipsychotics medications as inactive metabolites. Most first-generation antipsychotics are safe in chronic kidney disease and do not require any dose adjustment. Among the first-generation antipsychotic medications, haloperidol is the safest drug. Naltrexone has an important role in management of alcohol use disorder and opioid use disorder. The kidney majorly excretes naltrexone and its primary metabolite, so caution is needed while prescribing naltrexone in severe renal impairment. Drugs causing renal impairment include lithium, non-steroidal anti-inflammatory drugs, chemotherapy drugs, and antimicrobial agents. The recommended psychotropics in renal impairment are as follows. For antipsychotics, haloperidol can be given for 2 to 6 mg per day. Olanzapine can be given for 5 mg per day. Under antidepressants, sertraline and fluoxetine with alternate day dosing at lower glomerular filtration rate can be suggested. For mood stabilizers, start low dose of valproate or lamotrigine with monitoring of adverse effects. Antipsychotics and hypnotics, excessive sedation is more likely to occur in patients with renal impairment. So lorazepam and tropiclone are suggested. For anti-dementia drugs, rivastigmine is reasonable choice. The references are taken from the Maudsley Psychiatric 14th edition by David M. and practice guidelines for physical health condition in psychiatry and direction principle practice. मैम मॉनिटरिंग करेंगे मैम ट्रेनिंग मैम नॉर्मल AST and AIT. Greater than 60 mg. Pause.
Good morning, everyone. My topic for today is thiamine supplementation in alcohol use disorder. So, thiamine, it is also known as vitamin B1. It has an essential role for normal cell function and growth and development. Health benefits, we can get thiamine from yeast, pork, lentils, and oats. Health benefits of vitamin B1 are it boosts energy production, improves memory and brain function, can help with depression, improves cardiovascular health, can help with kidney issues. Symptoms of deficiencies are loss of appetite, fatigue, irritability, slower reflexes, and muscle weakness. Risk of supplementation. There is no upper limit for thiamine and dose up to 50 mg appear to be safe. When overdoing your supplementation, thiamine deficiency is most commonly caused by alcoholism. Thiamine deficiency primarily affects the cardiovascular system like heart failure and sodium water retention and nervous system. Thiamine deficiency is the established cause of an alcohol-linked neurological disorder known as Wernicke-Korsakoff syndrome and other forms of alcohol-induced brain injury. Wernicke's-Korsakoff is an acute severe condition, while Korsakoff psychosis is a chronic neuropsychiatric syndrome. Approx 80 to 90% patients of Wernicke's encephalopathy develops Korsakoff psychosis. Uh, these are the differences between Wernicke's encephalopathy and Korsakoff syndrome. In Wernicke's encephalopathy, confusion, ophthalmoplegia, ataxia is seen, while in Korsakoff there is retrograde amnesia and anterograde amnesia, confabulation. In Wernicke's, the affected part of brain are cerebellum, brainstem, and mammillary bodies. And in Korsakoff, limbic system is affected. Thiamine actions in the cell. Thiamine is required as a cofactor mainly in three enzymes that are transketolase, alpha-ketoglutarate dehydrogenase, and pyruvate dehydrogenase. These enzymes plays an important role in the catabolism of carbohydrates. Transketolase is a major enzyme in pentose phosphate pathway. And pyruvate dehydrogenase in glycolysis and alpha ketoglutarate dehydrogenase in citric acid cycle. Thiamine uptake into the cell, uptake from the intestine into the cells that line the intestine, transport out of those cells into the bloodstream, then uptake from the blood into the tissues and cells. For thiamine transported to the brain, this also includes crossing the blood-brain barrier, transport within the cells to the areas where the thiamine is needed. Example to the cell's energy factories, the mitochondria, where PDH and alpha ketoglutarate dehydrogenase act, or to the nucleus, where thiamine regulates gene activity. Thiamine deficiency in alcohol abusers results from inadequate dietary intake, reduced gastrointestinal absorption on consumption with alcohol, decreased hepatic storage, and impaired utilization. Treatment. Thiamine deficiency can be treated by stopping alcohol consumption, eating a nutritious diet, and by taking vitamin B1 supplements. However, diet and supplements alone are not effective if heavy alcohol use continues because alcohol will block absorption. In alcohol dependence, according to guidance, recommends prescribing prophylactic oral thiamine for harmful or dependent drinkers in the following circumstances. If they are malnourished or at risk of malnourishment, if they have decompensated liver disease, if they are in acute withdrawal, before and during a planned medically assisted alcohol withdrawal. Oral thiamine should be prescribed in doses toward the upper end of the BNF dosage, that is 200 to 300 milligram daily in divided doses, for as long as malnutrition is present and or during periods of continued alcohol consumption. Patients should be reviewed at appropriate intervals, and for those who complete alcohol withdrawal, remain abstinent after 6 weeks and regain adequate nutritional status. Thiamine prescription should be reviewed with a view to stopping. These are the references. Thank you. मैम वो ये वाले एंजाइम्स को ब्लॉक करा देता है, तो फिर मैम जो ये राइबोज बाइफॉस्फेट और एनएडीपीएच वहाँ पे बन जाए, वो उनकी डिप्लीशन हो जाती है। मैम एनर्जी प्रोवाइड करा देती है।
Vitamin K is the only fat soluble vitamin. Vitamin K is the only fat soluble vitamin with specific enzyme function. It is required for production of blood clotting factors. Vitamin K exists in different forms. Vitamin K1 is phyloquinone, which is present in plants. Vitamin K2, menoquinone, present by intestinal bacteria and present in plants. Vitamin K3, minodione, it is present in synthetic form. The three vitamins are stable to read. Their activities, however, lost by oxidizing agents and irradiation, strong acid and vitamins. Vitamin K is taken from the diet or synthesized by the intestinal bacteria, which are observed in the jejunum along with the phytomicrons. They they go through the lymphatics and stored in the liver. Vitamin K, it can be adequately synthesized in the gut. It is, however, recommended that half of the body requirement is provided in the diet, while the other half is made from the bacterial synthesis. According to the suggested RDA for adult is 70 to 140 micrograms per day. Dietary sources of cabbage, spinach, cauliflower, meat, tomatoes, cheese, and vegetables. Deficiency symptoms. Deficiency of vitamin K is uncommon since it is present in the diet in sufficient quantity. However, vitamin K deficiency may occur due to difficulty absorption, loss of vitamin into feces, and administration of antibiotics. Due to deficiency, individual bleeds profusely even for microinjuries. Hypervitaminosis K, administration of large dose of vitamin K produces hemolytic anemia and jaundice, particularly in infants. Role of vitamin K in psychiatry. Vitamin K in particular, it has been linked to protection against oxidative stress in brain mechanism, thought to be important in preventing depression. In addition, vitamin K concentration in the brain in animals models has been observed in parallel with the dietary intake.